Action concept exemplar, peptic ulcer disease. Peptic ulcer disease results when GI mucosal defenses become impaired and no longer protect the epithelium from the effects of acid and pepsin. Pathophysiology review. Types of ulcers. 3 types of peptic ulcers may occur: duodenal ulcers, gastric ulcers, and stress ulcers. Many ulcers are caused by H. pylori infection. The most common route of H. pylori infection transmission is either oral-to-oral or fecal-to-oral contact. As a response to the bacteria, cytokines, neutrophils, and other substances are activated and cause epithelial cell necrosis. Urease produced by H. pylori breaks down urea into ammonia, which neutralizes the acidity of the stomach. In addition, the helical shape of H. pylori allows the bacterium to burrow into the mucus layer of the stomach and become undetectable by the body's immune cells. Although this bacterium does not cause illness in most people, it is a major risk factor for peptic ulcers and gastric cancer. Duodenal ulcers occur more often than other types. Most duodenal ulcers present in the upper portion of the duodenum. They are deep, sharply demarcated lesions that penetrate through the mucosa and submucosa into the muscularis propria. The floor of the ulcer consists of a necrotic area residing on granulation tissue and surrounded by areas of fibrosis. The main feature of a duodenal ulcer is high gastric acid secretion, although a wide range of secretory levels are found. In patients with duodenal ulcers, pH levels are low in the duodenum for long periods. Protein-rich meals, calcium, and vagus nerve excitation stimulate acid secretion. Combined with hypersecretion, a rapid emptying of food from the stomach reduces the buffering effect of food and delivers a large acid bolus to the duodenum. Inhibitory secretory mechanisms and pancreatic secretion may be insufficient to control the acid load. Common examples of drug therapy: gastritis and peptic ulcer disease. Class and common examples selected: nursing implications. Antacids. Increase pH of gastric contents by deactivating pepsin. Magnesium hydroxide with aluminum hydroxide give 2 hours after meals and at bedtime. Hydrogen ion load is high after ingestion of foods. Use liquid rather than tablets. Suspensions are more effective than chewable tablets. Do not give other drugs within 1 to 2 hours of antacids. Antacids interfere with absorption of other drugs. Assess patients for a history of chronic kidney disease. Hypermagnesemia may result, especially in patients with poorly functioning kidneys, thus causing toxicity. Assess the patient for a history of heart failure. Inadequate renal perfusion from heart failure decreases the ability of the kidneys to excrete magnesium, thus causing toxicity. Observe the patient for the side effect of diarrhea. Magnesium often causes diarrhea. Aluminum hydroxide give 1 hour after meals and at bedtime. Hydrogen ion load is high after ingestion of food. Use liquid rather than tablets if palatable. Suspensions are more effective than chewable tablets. Do not give other drugs within 1 to 2 hours of antacids. Antacids interfere with absorption of other drugs. Observe patients for the side effect of constipation. If constipation occurs, consider alternating with magnesium antacid. Aluminum causes constipation, and magnesium has a laxative effect. Use for patients with chronic kidney disease. Aluminum binds with phosphates in the GI tract. This antacid does not contain magnesium. 2 antagonists. Decrease gastric acid secretions by blocking histamine receptors in parietal cells. Famotidine gives single dose at bedtime for treatment of heartburn and PUD. Bedtime administration suppresses nocturnal acid production. Nizatidine. Note: famotidine may also be given to prevent surgical stress ulcers. Mucosal barrier fortifiers. Protect stomach mucosa. Sucralfate give 1 hour before and 2 hours after meals and at bedtime. Food may interfere with drugs' adherence to mucosa. Do not give within 30 minutes of giving antacids or other drugs. Antacids may interfere with effect. Bismuth subsalicylate remind patient to refrain from taking aspirin while on this drug. Aspirin is a salicylic acid and can lead to overdose. Proton pump inhibitors. Suppress HK, ATPase enzyme system of gastric acid secretion to suppress acid. Omeprazole have patients take capsule whole. Do not crush. Delayed release capsules allow absorption after granules leave the stomach. Give 30 minutes before the main meal of the day. The proton pump is activated by the presence of food. Therefore, the drug needs a chance to work before the patient eats. Lansoprazole give 30 minutes before the main meal of the day. The proton pump is activated by the presence of food. Therefore, the drug needs a chance to work before the patient eats. Rabeprazole take after the morning meal. This drug promotes healing and symptom relief of duodenal ulcers. Do not crush capsule. This drug is a sustained-release capsule. Pantoprazole do not crush. This drug is enteric-coated. For form must be given on a pump with a filter and in a separate line. Given 4, this drug precipitates easily. Do not give 4-pantoprazole with other 4 drugs. Monitor for adverse drug interactions if patient is on other medications. The 4 form is not compatible with most other drugs. This drug will alter how other drugs are metabolized, either increasing or decreasing their effectiveness. Esomeprazole assess for hepatic impairment. Patients with severe hepatic problems need a low dose. Do not give Nexium 4 with other 4 drugs. The 4 form is not compatible with most other drugs. Monitor for adverse drug interactions if patient is on other medications. This drug will alter how other drugs are metabolized, either increasing or decreasing the effectiveness. Class and common examples selected nursing implications. Prostaglandin analogs. Stimulate mucosal protection and decrease gastric acid secretions. Misoprostol not commonly given, but used for clients receiving NSAIDs to protect the stomach mucosa. Avoid magnesium-containing antacids. Misoprostol and magnesium-containing antacids can cause diarrhea. Do not administer to pregnant women. This drug can cause abortion, premature birth, or birth defects. Antimicrobials. Treat H. pylori infection. Clarithromycin give with caution to patients with renal impairment. Monitor renal function laboratory values. This drug can increase the patient's BUN level and should be monitored. Amoxicillin teach patients to take the drug with food or immediately after a meal. This drug can cause GI disturbances, including nausea, vomiting, and diarrhea. Tetracycline teach patients to take the drug at least 1 hour before meals or 2 hours after meals. Dairy products and other foods may interfere with drug absorption. Teach patients to avoid direct sunlight and wear sunscreen when outdoors. This drug can cause the skin to burn as a result of photosensitivity. Metronidazole teach patients to take the drug with food. This drug can cause GI disturbances, especially nausea. Teach patients to avoid alcohol during drug therapy and for at least 3 days after therapy is completed. The patient can experience a drug-alcohol reaction, including severe nausea, vomiting, and headache. BUN, blood urea nitrogen, peptic ulcer disease. Fig. 501, most common sites for peptic ulcers. Gastric ulcers usually develop in the antrum of the stomach near acid-secreting mucosa. When a break in the mucosal barrier occurs, hydrochloric acid injures the epithelium. Gastric ulcers may then result from back diffusion of acid or dysfunction of the pyloric sphincter. Without normal functioning of the pyloric sphincter, bile refluxes into the stomach. This reflux of bile acids may break the integrity of the mucosal barrier, which leads to mucosal inflammation. Toxic agents in bile then destroy the membrane of the gastric mucosa. Gastric emptying is often delayed in patients with gastric ulceration. This causes regurgitation of duodenal contents, which worsens the gastric mucosal injury. Decreased blood flow to the gastric mucosa may also alter the defense barrier and thereby allow ulceration to occur. Stress ulcers are acute gastric mucosal lesions occurring after an acute medical crisis or trauma, such as sepsis or a head injury. In the patient who is NPO for major surgery, gastritis may lead to stress ulcers. Patients who are critically ill, especially those with extensive burns, sepsis, or increased intracranial pressure, are also susceptible to these ulcers. Stress ulcers are associated with lengthened hospital stay and increased mortality rates. Therefore, most patients who have major trauma or surgery receive 4 drug therapy to prevent stress ulcer development. Bleeding caused by gastric erosion is the main manifestation of acute stress ulcers. Multifocal lesions associated with stress ulcers occur in the stomach and proximal duodenum. These lesions begin as areas of ischemia and evolve into erosions and ulcerations that may progress to massive hemorrhage. Complications of ulcers. The most common complications of PUD are hemorrhage, perforation, pyloric obstruction, and intractable disease. Hemorrhage is the most serious complication. It tends to occur more often in patients with gastric ulcers and in older adults. Many patients have a second episode of bleeding if underlying infection with H. pylori remains untreated. Key features. Upper GI bleeding. 1. Bright red or coffee ground vomitus. 2. Melena. 3. Decreased hemoglobin and hematocrit. 4. Decreased blood pressure. 5. Increased heart rate. 6. Weak peripheral pulses. 7. Acute confusion. 8. Vertigo. 9. Dizziness or lightheadedness. 10. Syncope, or if therapy does not include an 2 antagonist. With massive bleeding, the patient vomits bright red or coffee ground blood. Gastric acid digestion of blood typically results in the coffee ground appearance. Hematemesis usually indicates bleeding at or above the duodenojejunal junction. Other signs and symptoms are listed in the key features, upper GI bleeding box. Minimal bleeding from ulcers manifests with occult blood in a dark, tarry stool. Melena may occur in patients with gastric ulcers but is more common in those with duodenal ulcers. Gastric and duodenal ulcers can perforate and bleed. Perforation occurs when the ulcer becomes so deep that the entire thickness of the stomach or duodenum is worn away. The stomach or duodenal contents can then leak into the peritoneal cavity. Sudden, sharp pain begins in the mid-epigastric region and spreads over the entire abdomen. The amount of pain correlates with the amount and type of GI contents spilled. The classic pain causes the patient to be apprehensive. The abdomen is tender, rigid, and board-like as a result of this infection. The patient often assumes a fetal position to decrease the tension on the abdominal muscles. He or she can become severely ill within hours. Bacterial septicemia and hypovolemic shock can follow. Peristalsis diminishes, and paralytic ileus develops. Peptic ulcer perforation is a surgical emergency and can be life-threatening. NCLEX Examination Challenge 501. Safe and effective care environment. The nurse is caring for a client diagnosed with peptic ulcer disease. For which potential complications will the nurse monitor? Select all that apply. A. Pneumonia. B. Peritonitis. C. Anemia. D. Stroke. E. Hypotension. F. Cirrhosis. Pyloric obstruction occurs in a small percentage of patients and manifests with vomiting caused by stasis and gastric dilation. Obstruction occurs at the pylorus and is caused by scarring, edema, inflammation, or a combination of these factors. Symptoms of obstruction include abdominal bloating, nausea, and vomiting. When vomiting persists, the patient may have metabolic alkalosis from loss of large quantities of acid gastric juice in the vomitus. Hypokalemia may also result from the vomiting or metabolic alkalosis. Fig. 502 common causes of upper GI bleeding. Many patients with ulcers have a single episode with no recurrence. However, intractability may develop from complications of ulcers, excessive stressors in the patient's life, or an inability to adhere to long-term therapy. He or she no longer responds to conservative management, or recurrences of symptoms interfere with ADLs. In general, the patient continues to have recurrent pain despite treatment. Those who fail to respond to traditional treatments or who have a relapse after discontinuation of therapy are referred to a gastroenterology practitioner. Etiology and genetic risk. Peptic ulcer disease is caused most often by bacterial infection with H. pylori and long-term use of NSAIDs such as ibuprofen. NSAIDs break down the mucosal barrier and disrupt the mucosal protection mediated systemically by cyclooxygenase inhibition. Other risk factors for PUD are the same as for gastritis. Patients with duodenal ulcers often have a positive family history of the disease. Incidence and prevalence. PUD affects millions of adults across the world. In the United States, the prevalence of PUD is over 15 million. However, primary healthcare provider visits, hospitalizations, and the mortality rate for PUD have decreased in the past few decades, in part because of the use of proton pump inhibitors and earlier treatment for H. pylori. Interprofessional collaborative care. Care of the patient with PUD generally takes place in the community setting unless the patient develops a more serious condition such as upper GI bleeding, which requires acute management. Table 502. Featured gastric ulcer, duodenal ulcer. Age 50 to 70 years. 20 to 50 years. Gender affects males and females equally, affects males and females equally. Blood group no differentiation, most often type O. General nourishment may be malnourished, usually well-nourished. Stomach acid production, normal secretion or hyposecretion, hypersecretion. Occurrence mucosa exposed to acid pepsin secretion, mucosa exposed to acid pepsin secretion, positive family history. Clinical course healing and recurrence. Upper abdominal pain occurs 30 to 60 minutes after a meal, at night, rarely occurs 112 to 3 hours after a meal, at night, often awakens patient between 1 and 2 a.m. Worsened by ingestion of food, relieved by ingestion of food. Response to treatment, healing with appropriate therapy, remissions and exacerbations. Hemorrhage, hematemesis more common than melena, more common than hematemesis. Cancer risk increased, but in less than 10%, not increased. Recurrence tends to heal and recurs often in the same location. 60% recur within 1 year, 90% recur within 2 years. Surrounding mucosa, atrophic gastritis, no gastritis. Differential features of gastric and duodenal ulcers. Assessment, recognize cues. History. A history of current or past medical conditions focuses on GI problems, particularly any history of diagnosis or treatment for H. pylori infection. Review all prescription and OTC drugs the patient is taking. Specifically inquire whether the patient is taking corticosteroids, chemotherapy, or NSAIDs. Also ask whether he or she has ever undergone radiation treatments. Assess whether the patient has had any GI surgeries, especially a partial gastrectomy, which can cause chronic gastritis. Collect data related to the causes and risk factors for peptic ulcer disease. Question the patient about factors that can influence the development of PUD, including alcohol intake and tobacco use. Note if certain foods such as tomatoes or caffeinated beverages precipitate or worsen symptoms. Information regarding actual or perceived daily stressors should also be obtained. A history of GI upset, pain and its relationship to eating and sleep patterns, and actions taken to relieve pain are also important. Inquire about any changes in the character of the pain because this may signal the development of complications. For example, if pain that was once intermittent and relieved by food and antacids becomes constant and radiates to the back or upper quadrant, the patient may have ulcer perforation. However, many adults with active duodenal or gastric ulcers report having no ulcer symptoms. Physical assessments/signs and symptoms. Physical assessment findings may reveal epigastric tenderness and pain, usually located at the midline between the umbilicus and the xiphoid process. If perforation into the peritoneal cavity is present, the patient typically has a rigid, board-like abdomen accompanied by rebound tenderness and intense pain. Initially, auscultation of the abdomen may reveal hyperactive bowel sounds, but these may diminish with progression of the infection. Perform a comprehensive pain assessment. Dyspepsia is the most commonly reported symptom associated with PUD is typically described as sharp, burning, or gnawing pain. Some patients may perceive discomfort as a sensation of abdominal pressure or of fullness or hunger. Specific differences between gastric and duodenal ulcers are listed in Table 502. To assess for fluid volume deficit that may occur from a bleeding ulcer, take orthostatic blood pressures and monitor for signs and symptoms of dehydration. Also assess for dizziness, especially when the patient is upright, because this is a symptom of fluid volume deficit. Older adults often experience dizziness when they get out of bed and are at risk for falls. Psychosocial assessment. Assess the impact of ulcer disease on the patient's lifestyle, occupation, family, and social and leisure activities. Evaluate the impact that lifestyle changes will have on the patient and family. This assessment may reveal information about the patient's ability to adhere to the prescribed treatment regimen and obtain the needed social support to alter his or her lifestyle. Laboratory assessment. There are 3 simple, non-invasive tests to detect H. pylori in the patient's blood, breath, or stool. Although the breath and stool tests are considered more accurate, serologic testing for H. pylori antibodies is the most common method to confirm H. pylori infection. The urea breath test involves swallowing a capsule, liquid, or pudding that contains urea with a special carbon atom. After a few minutes, the patient exhales, and, if the special carbon atom is found, the bacterium is present. The stool antigen test is performed on a stool sample provided by the patient, which is tested for H. pylori antigen. Patients who have bleeding from a peptic ulcer may have decreased hemoglobin and hematocrit values. The stool may also be positive for occult blood if bleeding is present. Other diagnostic assessment. The major diagnostic test for PUD is esophagogastroduodenoscopy, which is the most accurate means of establishing a diagnosis. Direct visualization of the ulcer crater by EGD allows the primary healthcare provider to take specimens for H. pylori testing and biopsy and cytologic studies for ruling out gastric cancer. The rapid urease test can confirm a quick diagnosis because urease is produced by the bacteria in the gastric mucosa. EGD may be repeated at 4 to 6 week intervals while the primary healthcare provider evaluates the progress of healing in response to therapy. Chapter 48 describes this test in more detail. GI bleeding may be tested using a nuclear medicine scan. No special preparation is required for this scan. The patient is injected with a contrast medium, and the GI system is scanned for the presence of bleeding after a waiting period. A second scan may be done 1 to 2 days after treatment for the bleeding to determine if the interventions were effective. Analysis, analyze cues and prioritize hypotheses. The priority collaborative problems for patients with peptic ulcer disease include 1. Acute or persistent pain due to gastric and/or duodenal ulceration. 2. Potential for upper GI bleeding due to gastric and/or duodenal ulceration or perforation. Planning and implementation, generate solutions and take action. Managing acute or persistent pain. Planning expected outcomes. The patient with PUD is expected to report pain control as evidenced by no more than a 3 on a 0 to 10 pain intensity scale. Interventions. PUD causes significant discomfort that affects many aspects of daily living. Interventions to manage pain focus on drug therapy and dietary changes. Drug therapy. The primary purposes of drug therapy in the treatment of PUD are to provide pain relief, eliminate H. pylori infection, heal ulcerations, and prevent recurrence. Several different regimens can be used. Although numerous drugs have been evaluated for the treatment of H. pylori infection, no single agent has been used successfully against the organism. A common drug regimen for H. pylori infection is PPI, triple therapy, which includes a proton pump inhibitor, such as lansoprazole, plus 2 antibiotics such as metronidazole and tetracycline or clarithromycin and amoxicillin for 10 to 14 days. Some primary healthcare providers may prefer to use quadruple therapy, which contains a combination of a proton pump inhibitor, any 2 commonly used antibiotics as described previously, and the addition of bismuth. Bismuth therapy is often used in patients who are allergic to penicillin-based medications. Bismuth subsalicylate inhibits H. pylori from binding to the mucosal lining and stimulates mucosal protection and prostaglandin production. Teach patients that they cannot take aspirin while on this drug because aspirin is a salicylic acid and could cause an overdose of salicylates. Patients should also be taught that bismuth may cause the stools and or tongue to be discolored black. This discoloration is temporary and harmless. Patient-centered care, older adult considerations. Many older adults have H. pylori infection that is undiagnosed because of vague symptoms associated with physiologic changes of aging and comorbidities that mask dyspepsia. Because the average age of gastric cancer diagnosis is 70 years, it is important to teach older adults about the symptoms of PUD and to consider H. pylori screening. Early detection and aggressive treatment can prevent PUD and gastric cancer. Hyposecretory drugs reduce gastric acid secretions and are therefore used for both peptic ulcer disease and gastritis management. The primary prescribed drugs include proton pump inhibitors and 2 receptor antagonists. A proton pump inhibitor is the drug class of choice for treating patients with acid-related disorders. Omeprazole, lansoprazole, and esomeprazole are each available as delayed-release capsules designed to release their contents after they pass through the stomach. Omeprazole and lansoprazole may be dissolved in a sodium bicarbonate solution and given through any feeding tube. Bicarbonate protects the dissolved omeprazole and lansoprazole granules in gastric acid. Therefore, the drugs are still absorbed correctly. These capsules can also be opened. The enteric-coated capsules can be put in apple juice or orange juice and given through a large bore feeding tube. Rabeprazole and pantoprazole are enteric-coated tablets that quickly dissolve after the tablet has moved through the stomach and should not be crushed before they are taken. Several of the PPIs, such as pantoprazole, are also available in N4 form, which is useful for patients who are NPO. Some patients use PPIs for years and perhaps a lifetime. These patients should be assessed periodically to determine the necessity of PPI use. Some studies have suggested there may be an increased risk of osteoporotic fractures related to long-term PPI use, yet current research is ongoing to determine if there is a definitive link. Omeprazole reduces the effect of clopidogrel, an antiplatelet drug. Teach patients to tell their primary healthcare provider if they are taking clopidogrel. PPIs should not be discontinued abruptly. To prevent rebound activation of the proton pump, a step-down approach over several days is recommended. Nutrition therapy. The role of diet in the management of ulcer disease is controversial. There is no evidence that dietary restriction reduces gastric acid secretion or promotes tissue healing, although a bland diet may assist in relieving symptoms. Food itself acts as an antacid by neutralizing gastric acid for 30 to 60 minutes. An increased rate of gastric acid secretion, called rebound, may follow. Nursing safety priority. Action alert. Teach the patient with peptic ulcer disease to follow healthy nutrition habits and avoid substances that increase gastric acid secretion. This includes caffeine-containing beverages. Both caffeinated and decaffeinated coffees should be avoided because coffee contains peptides that stimulate gastrin release. Teach the patient to exclude any foods that cause discomfort. A bland, non-irritating diet is recommended during the acute symptomatic phase. Bedtime snacks are avoided because they may stimulate gastric acid secretion. Eating 6 smaller meals daily may help, but this regimen is no longer a regular part of therapy. No evidence supports the theory that eating 6 meals daily promotes healing of the ulcer. This practice may actually stimulate gastric acid secretion. Patients should avoid alcohol and tobacco because of their stimulatory effects on gastric acid secretion. Complementary and integrative health. Teach patients about complementary and integrative therapies that can reduce stress, including hypnosis and imagery. For example, the use of yoga and meditation techniques has demonstrated a beneficial effect on anxiety disorders. Many have suggested that GI disorders result from the dysfunction of both the GI tract itself and the brain. This means that emotional stress is thought to worsen GI disorders such as peptic ulcer disease. Yoga may alter the activities of the central and autonomic nervous systems. Herbs and other supplements may be used by some patients as discussed earlier in this chapter under gastritis. Managing upper GI bleeding. Planning, expected outcomes. The patient with upper GI bleeding is expected to have bleeding promptly and effectively controlled and vital signs within normal limits. Interventions. Blood loss from PUD results in high morbidity and mortality. Fluid volume loss secondary to vomiting can lead to dehydration and electrolyte imbalances. Interventions aimed at managing complications associated with PUD include prevention and/or management of bleeding, perforation, and gastric outlet obstruction. In some cases, surgical treatment of complications becomes necessary. Non-surgical management. Because prevention or early detection of complications is needed to obtain a positive clinical outcome, monitor the patient carefully and immediately report changes to the rapid response team or primary healthcare provider. Emergency, upper GI bleeding. The patient who is actively bleeding has a life-threatening emergency and needs supportive therapy to prevent hypovolemic shock and possible death. Nursing safety priority. Critical rescue. Recognize that your priority for care of the patient with upper GI bleeding is to maintain airway, breathing, and circulation. Respond to these needs by providing oxygen and other ventilatory support as needed, starting 2 large bore 4 lines for replacing fluids and blood, and monitoring vital signs, hematocrit, and oxygen saturation. The purpose of managing hypovolemia is to expand intravascular fluid in a patient who is volume depleted. Carefully monitor the patient's fluid status, including intake and output. Fluid replacement in older adults should be closely monitored to prevent fluid overload. Serum electrolytes are also assessed because depletions from vomiting or nasogastric suctioning must be replaced. Volume replacement with isotonic solutions should be started immediately. The primary healthcare provider may prescribe blood products such as packed red blood cells to expand volume and correct a low hemoglobin and hematocrit. For patients with active bleeding, fresh frozen plasma may be given if the prothrombin time is 15 times higher than the mid-range control value. Continue to monitor the patient's hematocrit, hemoglobin, and coagulation studies for changes from the baseline measurements. With mild bleeding, slight feelings of weakness and mild perspiration may be present. When blood loss exceeds 1L/24HR, manifestations of hypovolemic shock may occur, such as hypotension, chills, palpitations, diaphoresis, and a weak, thready pulse. A combination of several different treatments, including nasogastric tube placement and lavage, endoscopic therapy, interventional radiologic procedures, and acid suppression, can be used to control acute bleeding and prevent rebleeding. If the patient is actively bleeding at home, he or she is usually admitted to the emergency department. After the bleeding has stopped, 2 receptor antagonists and proton pump inhibitors are the primary drugs used. Nasogastric tube placement and lavage. Upper GI bleeding or obstruction often requires the primary healthcare provider or nurse to insert a large bore NGT to 1. Determine the presence or absence of blood in the stomach. 2. Assess the rate of bleeding. 3. Prevent gastric dilation. 4. Administer lavage. Although not performed as commonly today, gastric lavage requires the insertion of a large bore NGT with installation of a room temperature solution in volumes of 200 to 300 milliliters. There is no evidence that sterile saline or sterile water is better than tap water for this procedure. Follow agency protocol for the solution that is required. The solution and blood are repeatedly withdrawn manually until returns are clear or light pink and without clots. Instruct the patient to lie on the left side during this procedure. The NGT may remain in place for a few days or be removed after lavage. Treatment of pyloric obstruction is directed toward restoring fluid and electrolyte balance and decompressing the dilated stomach. Obstruction related to edema and spasm generally responds to medical therapy. First, the stomach must be decompressed with nasogastric suction. Next, interventions are directed at correcting metabolic alkalosis and dehydration. The NGT is typically clamped after about 72 hours. Check the patient for retention of gastric contents. If the amount retained is not more than 50 milliliters in 30 minutes or other prescribed parameters, the primary healthcare provider may allow oral fluids. In some cases, surgical intervention may be required to treat PUD. Endoscopic therapy. Endoscopic therapy via an esophagogastroduodenoscopy can assist in achieving homeostasis during an acute hemorrhage by isolating the bleeding artery to embolize it. The endoscopist can insert instruments through the endoscope during the procedure to stop bleeding in 3 different ways: inject chemicals into the bleeding site, treat the bleeding area with heat, electric current, or laser, or close the affected blood vessels with a band or clip. During the EGD, a specialized endoscopy nurse and technician assists the physician with the procedure. Pre-EGD nursing care involves inserting 1 or 2 large bore catheters if they are not in place. A large catheter allows the patient to receive 4 moderate sedation and possibly a blood transfusion. Keep the patient NPO for 4 to 6 hours before the procedure. This prevents the risk for aspiration and allows the endoscopist to view and treat the ulcer. A patient must sign a consent form before the EGD after the primary healthcare provider informs him or her about the procedure. Nursing safety priority. Action alert. After esophagogastroduodenoscopy, monitor vital signs, heart rhythm, and oxygen saturation frequently per agency protocol until they return to baseline. In addition, frequently assess the patient's ability to swallow saliva. The patient's gag reflex may initially be absent after EGD because of anesthetizing of the throat with a spray before the procedure. After the procedure, do not allow the patient to have food or liquids until the gag reflex has returned. Endoscopic therapy is beneficial for most patients with active bleeding. However, ulcers that continue to bleed or continue to rebleed despite endoscopic therapy may require an interventional radiologic procedure or surgical repair. Interventional radiologic procedures. For patients with persistent, massive upper GI bleeding or those who are not surgical candidates, catheter-directed embolization may be performed. This endovascular procedure is usually done if endoscopic procedures are not successful or available. A femoral approach is most often used, but brachial access may be used. An arteriogram is performed to identify the arterial anatomy and find the exact location of the bleeding. The radiologist injects medication or other material into the blood vessels to stop the bleeding. Care of the patient following an arteriogram is similar to care following a percutaneous vascular intervention, which is described in chapters 30 and 33. Post-arteriogram nursing care should be provided after the procedure. Clinical Judgment Challenge 501. Safety, teamwork, and collaboration. A 52-year-old woman was admitted after vomiting bright red blood last night. She states that she has a history of gastritis and hypertension and takes medication for both. She cannot provide the names of the medications she is taking. This morning's nursing assessment findings include: states that she has been taking ibuprofen 1,600 milligrams every day for over a year for osteoarthritis in her hands and feet. Blood pressure equals 112/68 mmHg. Apical pulse equals 108 beats/min. Respirations equals 22 breaths/min. Has dry, pale skin. Has a slightly distended abdomen with mid-epigastric moderate pain. Is alert and oriented ×3. Has adequate bowel sounds ×4. 1. Recognize cues. What assessment information in this client situation is the most important and immediate concern for the nurse? 2. Analyze cues. What client conditions are consistent with the most relevant information? 3. Prioritize hypotheses. Which possibilities or explanations are most likely to be present in this client situation? Which possibilities or explanations are the most serious? 4. Generate solutions. What actions would most likely achieve the desired outcomes for this client? Which actions should be avoided or are potentially harmful? 5. Take action. Which actions are the most appropriate and how should they be implemented? In what priority order should they be implemented? 6. Evaluate outcomes. What client assessment would indicate that the nurse's actions were effective? Drug therapy. Aggressive acid suppression is used to prevent rebleeding. When acute bleeding is stopped and clot formation has taken place within the ulcer crater, the clot remains in contact with gastric contents. Acid suppressive agents are used to stabilize the clot by raising the pH level of gastric contents. Several types of drugs are used. 2 receptor antagonists prevent acid from being produced by parietal cells. Proton pump inhibitors prevent the transport of acid across the parietal cell membrane. Surgical management. Evidence-based guidelines for the treatment of PUD that include H. pylori treatment and the development of non-surgical means of controlling bleeding have led to a decline in the need for surgical intervention. In PUD, surgical intervention may be used to: 1. Treat patients who do not respond to medical therapy or other non-surgical procedures. 2. Treat a surgical emergency that develops as a complication of PUD, such as perforation. Two general surgical approaches are available for PUD: minimally invasive surgery and conventional open surgery. Minimally invasive surgery via laparoscopy may be used to remove a chronic gastric ulcer or treat hemorrhage from perforation. Several small incisions allow access to the stomach and duodenum. The patient may have partial stomach removal, pyloroplasty, and/or a vagotomy to control acid secretion. Acid reduction surgery may not be necessary because of the increased use of PPIs and endoscopic procedures in the treatment of PUD. The advantages of MIS over traditional open surgical procedures include a shorter hospital stay, fewer complications, less pain, and better, quicker recovery. Care of patients having gastric surgery is discussed later in this chapter under gastric cancer. Care coordination and transition management. Patients may be discharged from the hospital if there is no evidence of ongoing bleeding, orthostatic changes, or cardiopulmonary distress or compromise. Those discharged after treatment for peptic ulcer disease and/or complications secondary to the disease face several challenges to manage the disease successfully. Long-term adherence to drug therapy may require the patient to take several drugs each day. Permanent lifestyle alterations in nutrition habits must also be made. Home care management. Most patients are discharged to home to continue their recovery. Those who have had major surgery or complications, such as hemorrhage, may require 1 or 2 visits from a home care nurse to assess clinical progress, especially if the patient is an older adult. Self-management education. The primary focus of home care preparation is patient and family teaching regarding risk factors for the recurrence of PUD. Teach them how to recognize new complications and what to do if they occur. Help the patient plan ways to make needed lifestyle changes. For post-surgical patients, especially those who have undergone partial stomach removal, smaller meals may be required. Other postoperative nutrition changes are described in the self-management education discussion in the gastric cancer section. Home care considerations. The patient with peptic ulcer disease. Assess gastrointestinal and cardiovascular status, including 1. Vital signs, including orthostatic vital signs. 2. Skin color. 3. Presence of abdominal pain. 4. Character, color, and consistency of stools. 5. Changes in bowel elimination pattern. 6. Hemoglobin and hematocrit. 7. Bowel sounds, palpate for areas of tenderness. Assess nutritional status, including 1. Dietary patterns and habits. 2. Intake of coffee and alcohol. 3. Relationship of food ingestion to symptoms. Assess medication history. 1. Use of steroids. 2. Use of NSAIDs. 3. Use of over-the-counter medications. Assess patient's coping style. 1. Recent stressors. 2. Past coping style. Assess patient's understanding of illness and ability to adhere to the therapeutic regimen. 1. Symptoms to report to the primary healthcare provider. 2. Expected and side effects of medications. 3. Food and drug interactions. 4. Need for smoking cessation. Nursing safety priority. Action alert. Teach the patient who has peptic ulcer disease to seek immediate medical attention if experiencing any of these symptoms. 1. Sharp, sudden, persistent, and severe epigastric or abdominal pain. 2. Bloody or black stools. 3. Bloody vomit or vomit that looks like coffee grounds. Nursing safety priority. Action alert. Teach the patient who has had surgery for PUD to avoid any OTC product containing aspirin or other NSAIDs. Emphasize the importance of following the treatment regimen for H. pylori infection and healing the ulcer and of keeping all follow-up appointments. Help the patient identify situations that cause stress, describe feelings during stressful situations, and develop a plan for coping with stressors. Healthcare resources. If needed, refer the patient and family to the National Institute of Diabetes and Digestive and Kidney Diseases Health Information Center in the United States or to the Canadian Digestive Health Foundation. These groups provide information and support to patients who have digestive disorders. Evaluation. Evaluate outcomes. Evaluate the care of the patient with peptic ulcer disease based on the identified priority patient problems. The expected outcomes are that the patient 1. Does not have active PUD or H. pylori infection. 2. Verbalizes relief or control of pain. 3. Adheres to the drug regimen and lifestyle changes to prevent recurrence and heal the ulcer. 4. Does not experience upper GI bleeding. If bleeding occurs, it will be promptly and effectively managed. Gastric cancer. Most cancers of the stomach are adenocarcinomas. This type of cancer develops in the mucosal cells that form the innermost lining of any portion or all of the stomach. In general, gastric cancer is more common in males than in females, and there is a sharp increase in adults over 50 years of age. Often there are no symptoms in the early stages, and the disease is advanced when detected. Pathophysiology review. Gastric cancer usually begins in the glands of the stomach mucosa. Atrophic gastritis and intestinal metaplasia are precancerous conditions. Inadequate acid secretion in patients with atrophic gastritis creates an alkaline environment that allows bacteria to multiply. This infection causes mucosa-associated lymphoid tissue lymphoma, which starts in the stomach. Gastric cancer spread by direct extension through the gastric wall and into regional lymphatics, which carry tumor deposits to lymph nodes. Direct invasion of and adherence to adjacent organs may also result. Hematogenous spread via the portal vein to the liver and via the systemic circulation to the lungs and bones is the most common mode of metastasis. Peritoneal seeding of cancer cells from the tumor areas to the momentum, peritoneum, ovary, and pelvic cul-de-sac can also occur. In adults with advanced gastric cancer, there is invasion of the muscularis or beyond. These lesions are not cured by surgical resection. The overall 5-year survival rate of adults with stomach cancer in the United States is poor because most patients have no symptoms until the disease advances. Infection with H. pylori is the largest risk factor for gastric cancer because it carries the cytotoxin-associated gene A gene. Patients with pernicious anemia, gastric polyps, chronic atrophic gastritis, and achlorhydria are 2 to 3 times more likely to develop gastric cancer. The disease also seems to be positively correlated with eating excessive pickled foods, nitrates from processed foods, and salt added to food. The ingestion of these foods over a long period can lead to atrophic gastritis, a precancerous condition. A low intake of fruits and vegetables is also a risk factor for cancer. Gastric surgery seems to increase the risk for gastric cancer because of the possible development of atrophic gastritis, which results in changes to the mucosa. Patients with Barrett esophagus from prolonged or severe gastroesophageal reflux disease have an increased risk for cancer in the cardia. Chapter 49 discusses GERD and esophageal cancer in detail. Interprofessional collaborative care. Care of the patient with gastric cancer takes place in all settings, ranging from the home and community environment to the inpatient setting, depending on the stage of disease and the immediate course of treatment. Assessment, recognize cues. Although patients with early gastric cancer may be asymptomatic, dyspepsia and abdominal discomfort are the most common symptoms. However, these symptoms are often ignored, or a change in diet or use of antacids relieves them. As the tumor grows, these symptoms become more severe and do not respond to nutrition changes or drug therapy. In patients with advanced disease, anemia is evidenced by low hematocrit and hemoglobin values. Patients may have macrocytic or microcytic anemia associated with decreased iron or vitamin 12 absorption. The stool may be positive for occult blood. Hypoalbuminemia and abnormal results of liver tests occur with advanced disease and hepatic metastasis. The level of carcinoembryonic antigen is elevated in advanced cancer of the stomach. The primary healthcare provider uses esophagogastroduodenoscopy with biopsy for definitive diagnosis of gastric cancer. The lesion can be viewed directly, and biopsies of all visible lesions can be performed to determine the presence of cancer cells. During the endoscopy, an endoscopic ultrasound of the gastric mucosa can also be performed. This technology allows the primary healthcare provider to evaluate the depth of the tumor and the presence of lymph node involvement, which permits more accurate staging of the disease. CT, positron emission tomography, and MRI scans of the chest, abdomen, and pelvis are used in determining the extent of the disease and planning therapy. Key features: early versus advanced gastric cancer. Early gastric cancer. 1. Dyspepsia. 2. Abdominal discomfort initially relieved with antacids. 3. Feeling of fullness. 4. Epigastric, back, or retrosternal pain. Advanced gastric cancer. 1. Nausea and vomiting. 2. Iron deficiency anemia. 3. Palpable epigastric mass. 4. Enlarged lymph nodes. 5. Weakness and fatigue. 6. Progressive weight loss. Interventions. Take action. Management of gastric cancer includes drug therapy, radiation, and/or surgery. Drug therapy and radiation may be used instead of surgery or as an adjunct before and/or after surgery. Non-surgical management. The treatment of gastric cancer depends highly on the stage of the disease. Radiation and chemotherapy commonly prolong survival of patients with advanced gastric disease. Combination chemotherapy with multiple cycles of drugs such as cisplatin and irinotecan before and after surgery may be given. Bone marrow suppression, nausea, and vomiting are common adverse drug effects. Chapter 20 discusses the general nursing care of patients receiving chemotherapy. Although gastric cancers are somewhat sensitive to the effects of radiation, the use of this treatment is limited because the disease is often widely spread to other abdominal organs at diagnosis. Organs such as the liver, kidneys, and spinal cord can endure only a limited amount of radiation. Intraoperative radiotherapy is available in large tertiary care healthcare systems. Surgical management. Surgical resection by removing the tumor is the preferred method for treating gastric cancer. The primary surgical procedures for the treatment of gastric cancer are total and subtotal gastrectomy. In early stages, laparoscopic surgery plus adjuvant chemotherapy or radiation may be curative. Patients having MIS have less pain, shorter hospital stays, rare postoperative complications, and quicker recovery. However, MIS is performed less often in the United States than in Europe because very few patients are diagnosed in the early stage of the disease. A recent study in a U.S. cancer center examined outcomes of MIS and an enhanced recovery after surgery protocol. In addition to expected outcomes associated with laparoscopic surgery, patients in the study advanced their diets more quickly, experienced less weight loss, and increased their physical activity more quickly within the first week after the procedure when compared with patients having open traditional surgery. Most patients with advanced disease are candidates for palliative surgical treatment. Metastasis in the supraclavicular lymph nodes, inguinal lymph nodes, liver, umbilicus, or perirectal wall indicates that the opportunity for cure by resection has been lost. Palliative resection may significantly improve the quality of life for a patient with obstruction, hemorrhage, or pain. Preoperative care. Before conventional open-approach surgery, a nasogastric tube is often inserted and connected to suction to remove secretions and empty the stomach. This allows surgery to take place without contamination of the peritoneal cavity by gastric secretions. The NGT remains in place for a few days after surgery to prevent the accumulation of secretions, which may lead to vomiting or GI distension and pressure on the incision. Patients having laparoscopic surgery do not require an NGT. Because weight loss is problematic for patients with gastric cancer, nutrition therapy is a vital aspect of preoperative and postoperative management.